So, Ed, thank you for joining us here in our little discussion. Could you just tell us about your organisation and what your role is within that organisation?
So I work for an organization called Our World in Data, which is a scientific online publication, mainly a website based at the University of Oxford. It was created in 2013, so we've been around for a while. And the mission of the website is to publish research and data to make progress against the world's largest problems. This encompasses many different things, including before the pandemic. So we've been working for a long time on climate change, on inequality, on poverty, on education, on global health. But in 2020 in particular, we made the decision to start working on the pandemic, thinking that it was probably going to be one of the world's largest problems for the years to come. And so actually that's when I joined Our World in Data to become the head of data of the organization. Since then, my main job really on a daily basis has been to create, collect, and maintain different data sets on the pandemic. So we have all sorts of data sets on the website that people can visualize in terms of charts, bar charts, time series, maps on cases, deaths, testing, vaccination, and many other things. And outside of COVID, I also manage a team of 4 people who work on doing the same thing. So collecting and publishing data and making data visualization on different topics, including very recently a particular effort on climate change.
Fantastic, thank you. And Sandra, what's your organisation and your role within your organisation?
I actually work across 2 separate organisations, neighbouring boroughs, the Hackney, London Borough of Hackney and the City of London Corporation, and these are both local authorities. And although the City of London Corporation is actually a slightly more complicated organisation, it has local authority functions, and I'm the Director of Public Health for both. And that means that I have strategic responsibility for the health of the entire populations of Hackney and the City of London. And that involves a whole range of different things that I do, and that I have a team of about nearly 50 people. And we work on a whole range of different issues that are related to health. So some of it will be kind of familiar, mental health, for instance, but or commissioning services like sexual health services and substance misuse services. But we also work across the council, both local authorities and with a whole range of other partners, including the NHS and community and voluntary sector organisations, on things that are driving health and health inequalities, like poverty and like housing and employment, for instance, and also on other things that have an impact on health, like air quality. So, for instance, we've recently released our Hackney Air Quality Action Plan, which I'm the lead director for. And of course, we also work with what was previously Public Health England and is now the UK Health Security Agency, work in partnership with them on hazards to health, like from infectious diseases, or if there was a chemical release, or one of these sort of emergent health protection issues. And we work in partnership with them, and particularly over the last 20 months or so in the response to COVID, much more hands-on involvement in health protection than we normally would have, but on an ongoing basis, that's a partnership for protecting the health of the population. Significantly though, within my team, as many other public health teams have, we have a health intelligence team who, on a much, much smaller scale, do the same kind of work that Edouard does in terms of collating data from various different sources and turning that into intelligence and insights that people can take action on.
Oh, interesting. And just for those that are listening in who might not be based in London or are aware of London geography, just tell us about the sort of size of Hackney and the City of London, the population that you're looking after.
So it's in the East End of London, and the City of London itself is literally a square mile, or just slightly a bit more than a mile. and has a resident population of about 9,000. And Hackney, which is just north of it, and obviously a bit bigger, has a resident population of about 280,000. So that's the size of the resident population. I have responsibility for people who are based in the area for other reasons. I was going to say borough, but city isn't strictly a borough either. People who commute in for work, for instance, or who are based in the area for other reasons, maybe they come in because they have caring responsibilities, would also fall under my purview if there were an incident, for instance. And the City of London has, in normal times, pre-COVID, had around 500,000 commuters each day coming into each working day, anyway, weekday, coming into the cities, which obviously massively swell the city population and colours the view that we have around our approach to population health there.
Interesting, thank you. So Ed, the work that you're doing is really sort of taking data from around the world and looking at some really big world problems. So tell us about where your data comes from. It sounds like you're a team of 20 people managing all this data. Where's it coming from?
So it really comes from two main types of sources. So the first main type is international institutions. So that's when we kind of trust another organization with maybe more legitimacy to gather data, and we reuse their data to shape into a way that is more usable by people. So this is the case, for example, for COVID cases and COVID deaths, which are counted by Johns Hopkins University and have been counted by them since the pandemic started. This is also the case for hospital data, for example, which we take from the European CDC, and some other data that we take from sources such as the Blavatnik School of Government at the University of Oxford about public policy around COVID, or even from companies like Google on the mobility data. So the data showing whether people are moving less or more than before the pandemic, which was really interesting data, especially in the spring of 2020. So this is data that we basically take as is, and we reshape it and make it just much more usable for people. And so rather than opening a spreadsheet, they can just access a map or access the timeline and visualize the data much more usefully. And then there is a completely different type of data that we deal with, which is basically data sets that we've decided to create ourselves. So this is mainly the case for two things, which are testing, so PCR in the first place, and then antigen tests, and now vaccinations. So these are two instances where actually there is no organization that is doing this work of collecting the data and putting it together in one place. And so we are the organization doing this job. So for testing, we started this in April of 2020, thinking that on top of the cases and deaths, having data on the number of tests being done was extremely important. And it was revealed to be extremely important. And even now, we know that, for example, in Africa, there are many places where the number of cases is really just a function of the number of tests, which is really low. And so that gives us a very good intuition of how much can we trust the number of cases and how much can we trust the number of deaths if the testing is really low. And so this is something we started doing in the spring of 2020. And more recently, in December 2020, very importantly, we started doing the vaccination data. So this started when the UK vaccinated the first person in December. And really at that time, no organization kind of announced that they would be collecting the data. So we started doing it kind of thinking that maybe another organization would do it then, and it never really happened. And so up until now, we are still doing this. And so we are basically, for those two types of data, our job consists in each morning going to the website of each national government in all the countries in the world, collecting the latest number, which can be like the latest number of tests or the latest number of vaccinations done, and putting it into a spreadsheet that we maintain so that people can use that. And those people can be researchers, they can be governments, and they can be, especially in the case of the vaccination data, they can be media organizations that reuse this data to build dashboards and maps for their websites.
Very interesting, very interesting. So a lot of data processing to make it more accessible, palatable, and so forth for the general public as well as other organizations.
Exactly.
Yeah. And Sandra, what about you? Where does your data come from?
Well, we use lots of different sources. We don't actually develop any of our own databases, and there are some particular institutions in the UK, like PHE used to, now it's UKHSA and NHS, that collect data and make it available. But then there's also other sources of data that are actually really useful for understanding what's happening, like the Google mobility data, which a colleague in the City of London's been analysing for us, and we've been using that to understand about movements in the city, for instance. So we have data from that isn't only about health, cases, testing, vaccinations, but also some stuff about what's happening with the community, like, you know, how many people are requiring self-isolation support, and how many people in the early days last spring, I guess, how many people were actually contacting the councils for support because everyone was told to stay at home very suddenly and they didn't know what to do next. And so there's some other data that it doesn't sound like it's exactly about the pandemic, but actually it's just as important for us to understand what our response should be, you know, what's happening to people and what the response to that should be. And we work, not just my intelligence team, but with other departments that collate data or collect it directly. So for instance, the council contact centres count the number of calls they get and they know what they're about, and that's a really good source of insight. But in particular, we started working with the registrars, you know, who register births and deaths, to find out how many people from our local area were dying from COVID. And that wasn't information that was readily available to begin with. We were getting the national data that just told you how many tests there'd been and how, you know, how many cases and how many deaths at a national level. And to begin with, in the very early days, we had no information about what was happening locally. So just finding ways to extract information from people who have it is actually really important.
Absolutely. And can you give us an example of what you've done with that data? So data is great, right? We all like to read it. We all know what's going on, but what is it doing? So an example of what it's done for you.
Yeah, so it's the insights that are important, and I want to stress that because actually there's a lot of discussion. I mean, I know this is the Open Data Institute, but data by itself doesn't do anything. It has no meaning until you turn it into an insight. It's interesting sometimes, but it actually doesn't do anything on its own. So you have to understand the context of it, and then you can say, well, that's what we understand from these data in this context. That's the insight. So what we did was, to go back to the point about the registrars, is that we were hearing anecdotes about people dying while we were at that point not getting any information even about how many cases there'd been locally. And because we're the public health team, everyone's looking to us to interpret and understand what was going on. There was an article in a local paper about deaths in a particular community, the Orthodox Jewish community. We have a significant, it's a minority, but a significant, large minority of Orthodox Jewish people who live in an area of Hackney. And we were hearing from the community that there were cases, and then there was an article about deaths, but we weren't getting that information. So that's when we started that programme of working with the registrars so that we could get information about deaths, and that actually informed us about what was going on in the community. And we used that information in conversation with community leaders, rabbis, leaders of community organisations, to mobilise the community around what do you need to do to prevent the spread of infection. So that's the sort of thing we've been doing with the data.
Yeah, it's the interpretation of it, isn't it? And so Ed, I mean, obviously with your organisation, you are sort of pulling all this data together and putting it out there in a more presentable format. So how is your data being used either by your own organisation or other organisations? Do you have examples of that?
Yes, we've had, especially in the last 2 years, we've had plenty of examples. So to give you a few ones on the political front, our data has been used a lot in all the political debates that have happened in the last 2 years, and there have obviously been a lot. So both from governments and from the opposition in many countries. to try to explain that, public policy around COVID was good, was bad, was working, was not working. And especially because this is a particular thing that our interface allows people to do, to compare countries together. So a particular thing that we do is that people on our charts can select countries and compare their country to the neighbors or to countries with a similar profile. And this is something that is extremely useful because rather than have kind of an exhaustive map of all the entire world, but that doesn't really tell you anything in context, or just looking at your country, but being unable to compare it to other cases. It's really interesting, for example, for the UK to be able to compare itself to maybe the US, Canada, France, and Germany, or something like that. And so this is really something where in the political arena, let's say, we've seen a lot of uses of. Of course, and I should say that we've seen good uses of it and bad uses of it. And in particular, the sort of flip side of this thing I just said about being able to pick countries means you can also cherry pick countries. And we've seen plenty of examples of this from both, again, governments and opposition groups trying to make their particular country look either very good or very bad, depending on what they want to show by picking specific countries that they liked or they thought were doing much better. So that's the political side. On the research side, we've had also a lot of uses of our data. So this applies more to the second type of data I mentioned. So the data sets that we are building ourselves. In the case of the testing data, this is really useful data for research, especially to try to evaluate how many actual cases have been, how many actual infections have happened in a country. So we know that the number of confirmed cases is actually a fraction of the actual cases that have happened since the start of the pandemic. And the main way to try to calculate what has been the actual number of infections is to look at how many tests have been done, and especially to look at what we call the positive rate, which is the percentage of tests that come back positive. So that's been on the testing front. And of course, on the vaccination data, there's also been a lot of use recently to try and find out preliminary results, which are becoming more robust now, about whether vaccination is actually contributing to slowing down the pandemic and protecting the population. So this is for the research. On the media side, of course, there's been a lot of uses of our data as well. It's been a mix of very different situations. I mentioned the testing and the vaccination data. The vaccination data in particular has been used a lot, especially in the last 6 months, by virtually every media organization, because most big newspapers, such as the Guardian, the New York Times, the Washington Post, want to have their own vaccination tracker where people can follow different kind of charts and maps. So these are cases where they build their page with their own charts, but the underlying data is the data that we publish. And so they brought this data every day after the update, and they refresh their own charts. And I think that also beyond these kind of like very big example of very big media organizations, we've tried to make our data very useful to much smaller organizations or freelance journalists. And again, one of the useful things is that they can go on the website, explore many different metrics, choose the countries they want, and then export the charts, export dynamic chart that they can integrate into their articles. And this has helped a lot of journalists complete their own reporting with factual data without having to go through the process of working with a data journalist to do this from scratch. And finally, I think the fourth main use of other data has really been just a sort of transparency process of letting as many people as possible look at the data and try to find out what they think about the pandemic. Now, of course, this has also problems. And we know that in the last 2 years, there's been a lot of misinformation about the pandemic. And so this is something that we all have to deal with, and especially the media has a big role to play in this. But in a way, we feel pretty confident about the fact that the net effect is very positive when we allow people to not just trust data, but to trust what, for example, a government says or what a media organization says, but also to be able to look at the data on their own and find out what they think about a situation and how the situation is evolving. So yeah, these have been really the four main types of use of our data, and we see many different examples of how this is evolving every day. We regularly find out that people are using our data in ways that we didn't expect, and we're always very pleased to know that essentially our data is being used by people and reused, especially by people. It's not just about looking at those visualizations and like exporting an image, but it's also about people downloading the spreadsheets that we make available and doing their own research and their own analysis with it.
Fantastic, thank you.
And we've also used the open data just to get a sense of what's going on in the world and put what's happening in our little part of the world into that context.
Yeah. So as a scientist, so I do research as part of my main role. You know, with any research that we do, data is obviously so important, but missing data, incorrect data, gaps in data that you forgot to collect but would be really helpful is so important in research. So are there issues in terms of gaps or missing data for you and your organisation that are important that you're trying to address?
Well, you can always have more data. So I think missing data is a really interesting question. I think I suppose it depends on the specifics. So in the early part of the pandemic, for instance, we just didn't have data about what was going on. So in that sense, there was a massive gap, and it wasn't so much about the data set having gaps in it. It was just there wasn't a data set, and that was problematic because when you're trying to deal with an issue, especially if it's an emergent issue, you actually have to understand what's going on. And so without the information, clearly you don't understand what's going on. More generally, we would understand a lot more about the health of our populations if we did have more complete data on a whole range of different issues and characteristics. And so, for instance, at the moment, we're doing some work on reducing health inequalities, in particular looking at ethnic health inequalities, and data on how people define themselves in terms of ethnicity are really badly collected, or there are big gaps in practically every data set. And so some organisations do better at it. So, for instance, mental health hospitals generally are just much better at collecting ethnicity data than other hospitals are. I'm not entirely clear why. And health data sets where you know that when you register as a patient for the first time or you go to an outpatient appointment, whatever, they will always ask you a whole load of administrative questions, which will include this monitoring questionnaire where you can tick a box to signify your ethnicity according to that particular classification. You find big gaps in that, and I guess the way that it's being collected, and at the point that it's being collected, people aren't encouraging the respondents to complete it. But there's also the issue of people not recognising themselves in the categories. And so, for instance, when we look at vaccination uptake in the city in Hackney, we've got two fairly big categories of in the ethnicity classification, which are not reported and other, and up to 40% of the entire group can be other, and a significant proportion, which I can't remember off the top of my head, but it's well over 20%, is not reported. And so if people are saying other, that means I don't recognise myself, but that also means we can't recognise them in the data. Okay. And therefore, if there's an issue for people who are maybe Turkish and they don't identify as Asian or white or black, then how do we know? How do we measure it? And how does that even flag itself up to us when we can't interrogate the data and find that out? So one of the things that we're advocating for locally, but also in a London-wide project that I'm leading with another Director of Public Health from Lewisham, Catherine Mbuma, we're advocating for not just better completion of ethnicity data collection, but to find a way to get a more granular classification that's still able to be collected and analysed in a way that isn't going to blow the analyst's mind, but allows people to find a way to identify themselves much better within it. So that's one of the biggest gaps then, but there are others. So, other types of personal information where people think you can't tell by looking at me and therefore I don't necessarily need to disclose it, because I think that disclosing it might have an impact for me. It just makes it much easier for people to not disclose. And then the people who are asking you about it or giving you a form to fill in are not necessarily encouraging you to complete it, and people don't know what we're going to do with their data, which is the other issue. I can understand why people are sceptical or concerned about giving information, and I was like that for most of my life too. So I do understand that idea that you just don't want to disclose things to people when you don't know what they're going to do with it. So I think being more open about how we store it, what we do with it, when we've analysed it, what have we found out, who do we share it with, who will we never share it with, what do we do with it when we get to the end of its useful life and we are no longer going to store it, how do we make sure we've actually really scrubbed it, that kind of thing. Being really open about it, I think, would be helpful.
That's excellent points. And Ed, I guess over the pandemic, you would have gone from minimal amount of data to like volumes of data as things. So tell us about that sort of trajectory. What were you starting off with at the beginning and where have you got to now?
Yeah, so as you said, it started off really with the complete lack of data in the first few months. There was really this question of, I mean, it's also a time, and we have to remember that, where cases were counted by one, basically, and we weren't even counting the number of daily cases. We were all talking about the total number of cases because it was about like 13 cases, 14 cases. And so really there was just not much point at the beginning in counting things in spreadsheets, and people, like, it took some time for people to realize that, yes, this was going to be long enough and problematic enough that we would need actual files and actual databases describing this. And the problem is that it's also kind of helped shine light on the fact that many public health services, or even private health services, were simply not ready to collect and publish this data. So in many countries, including very developed countries, the current state of the health system in terms of informatics and computer systems means that it was extremely difficult to pull out this data and to sort of like collect it and gather it at a national level. Often one hospital in particular would, of course, know how many patients were admitted with COVID, but there was really a struggle for the health ministry to tell all the hospital in the country to send this data to the same place, to reconcile the numbers, to avoid any kind of double counting, and to be able to say then each day at 7 p.m. to the press, today we have 1,283 new cases. And we know for a fact that, for the first few months of the pandemic, often these numbers were very approximate figures. And yeah, so there was just a very deep lack of data. And as we know, the testing also took a lot of time to be implemented. And so for the first few months, we just didn't really know what was going on, and there was a complete lack of data. Then, as the months passed and all of that infrastructure was improved, especially in rich countries, we started having more and more data. The data was published more regularly, the quality improved. And so we started having much more granular data, broken down by age, by gender, by ethnicity. We started having whole time series, which sometimes also told us more about what happened in the first few weeks of the pandemic, because we had retrospective data showing us what actually happened in February and March. And as time went on, we started having, again, more data about different aspects of things like policymaking and mobility and things like this. Then, the vaccination started happening, and it was a very different situation for the vaccination. So there were, again, the first few weeks where in some countries, including the UK, for the first few weeks, it seemed like it was just happening all over again, and that the state of the computer system was just, again, not ready, and that it took a while to get actual daily numbers and to understand what was going on. But again, now, 10 months later, we had extremely granular data, almost too much data in some cases, data that we don't really know what to do with. But I think, on average, all things equal, it's always better to have more data than less data. But yeah, it's been really a complete change in this. And I think it's also linked to what Sandra was saying about the whole open data concept. I think One important thing about the pandemic is that I think it's going to be really difficult for big organizations and institutions and governments to go back to the way things were, in the sense that I think there's really this sort of compulsory need now to publish data. So that doesn't mean it's going to be easy, because again, on many other different topics, including health topics, the data is still kind of locked away in databases that no one can really access. But I think there's going to be a movement asking to obtain this data. And it's not just going to be about health, it's also going to be about policymaking, about private companies, about taxes, for example. And it seems like at least one good thing that would have come out of all this will have been this kickstarting this movement of convincing people and the broader public that having access to this data is really something essential.
Yeah.
Fantastic.
I agree with that, and I also think that not just convincing people that having the data is excuse me, that having the data is important, but also it's helping to increase the general data literacy in the population. And I think that's a really, if you can say there's a good outcome of the pandemic, that's one of the good outcomes of this.
So we are now a data-driven world. Well, I think we've come to the end of our time. So thank you both so much. Very interesting work, very different perspectives, and it's been great to hear from you.
Thank you.